Good afternoon to everyone. First of all, I want to thank IESS for inviting me to come here today and share a little bit about our journey in the United States around quality and safety of healthcare. This is actually my first visit to Brazil, and so far it's been a wonderful visit. The people here have been incredibly warm and welcoming. To reflect something that Fiona shared earlier, I definitely see this as an opportunity for shared learning. As much as we want to share about our experience, we'd love to hear about yours as well and maybe what we can learn from each other. So I'm going to talk today a little bit about an organization called the Leapfrog Group. I am at Johns Hopkins University. I'm a faculty member there, and I have a contract with the Leapfrog Group to provide them with scientific guidance around measurement for their annual hospital survey and hospital safety score. I've been working with the organization for about 9 years now. So the Leapfrog Group is a healthcare purchaser nonprofit organization. And when I use the word purchaser, what I mean by that typically is employers. There are other examples of healthcare purchasers. These could be unions, but I think for today and for understanding, when I talk about purchasers, I'm talking about employers who are buying healthcare benefits on behalf of their employees. So they are buying private insurance that their employees have that allows them to access the U.S. healthcare system. The Leapfrog Group is a nonprofit based in Washington, D.C., and they publicly report on the quality and safety of U.S. hospitals. The organization was founded in 2000 by large purchasers of healthcare, and I've included some of the founding members: General Motors, Marriott, General Electric, Boeing, FedEx. And those purchasers came together really in response to the Institute of Medicine report, To Err is Human, which found that anywhere between 44,000 and 98,000 Americans were dying in U.S. hospitals each year due to preventable medical mistakes. And for a company like General Motors, which at the time was very large, at the time they had about 1 million people, 1 million Americans who had their health insurance through General Motors. That 98,000 Americans actually translated into real numbers. The estimates are that it was 3 employees, retirees, and family members who were dying in U.S. hospitals each week. So these companies came together with the goal of how to use their collective leverage as purchasers to improve the quality and safety of care that was being delivered in U.S. hospitals. And the members really came together with 2 foci. The first one was a fundamental belief in transparency of data. They felt like that those who are using the healthcare system and those who are paying for the healthcare system have a fundamental right to understand how that system's operating. So transparency was number 1, what they wanted to achieve. The second was they wanted to be smart purchasers of healthcare. They wanted to make sure that they were buying high quality care for their beneficiaries and that that care was being delivered at a reasonable cost. And there were really 2 goals with transparency. The first one was to inform patients and purchasers' choice. So as patients looked for where to seek care in a hospital, they could use information about quality and safety in their decision-making, recognizing that it's not the only consideration that they have in making decisions about where to go for a hospital, but it's an important consideration. The second consideration was, how do they spur healthcare providers to improve? So by making data transparent, that really was a good impetus for healthcare providers themselves to understand where they were relative to their peers. My experience is that healthcare providers are a very bright, educated group of individuals who don't necessarily like being at the bottom of the pack. And so the transparency of the data has really been a good mode of improvement for healthcare providers to actually improve their own performance. I think what's been really novel about Leapfrog is early on it recognized that healthcare is local. When people seek healthcare, they're generally seeking it in an area that's near to home. ideally. And so Leapfrog early on identified that they needed both a regional approach and a national approach. I'm going to talk first about the regional role that Leapfrog has created. Leapfrog has created a set of regional leaders. At this point, there's somewhere between 40 and 50 regional leaders who are either employers or employer coalitions who act as the local face of Leapfrog. So one example I'll give you is in Seattle, Washington, which is where Boeing used to be based and still has a large operation. Boeing actually acts as the local face of Leapfrog in the Seattle area. They're the regional leader there. So it's actually Boeing who sends a letter to the hospitals in the Seattle area asking them to complete and share information about the quality and safety of care. And the letter is really something along the lines of, dear neighbor, we send a lot of our employees to your hospital, and we want to understand the quality and safety of care that you're providing to them. And that approach of local engagement has actually worked really well. Leapfrog recognized that sitting in Washington, D.C. and asking 5,000 hospitals across the country to engage in quality and safety reporting wasn't necessarily going to cut it, that you really needed a local face to make that successful. But there are some rules that are actually, I think, better served at a national level, where you do gain some efficiencies. These are things such as, when we develop our survey, which I'll talk about in a little bit, the measures we use on the survey are actually common across hospitals across the United States. The website where we do the public reporting of data is done out of the Washington, D.C. office. Communications about quality and safety are done out of D.C., and policy advocacy, where we're able to do that, is also done out of DC. So one of the areas I was asked to touch on a little bit was Leapfrog's funding. So Leapfrog was founded 16 years ago in 2000, and its seed funding came from some foundations. The biggest contributor was the Business Roundtable, which is the Fortune 200 CEO organization. They were very generous sponsors of getting the Leapfrog Group up and running. The CEOs of some of the companies I mentioned earlier, General Motors, GE, are part of the Business Roundtable, and so they got their colleagues to pitch in money for this effort. We also had funding from the Commonwealth Fund and the Robert Wood Johnson Foundation. 16 years later, we've actually evolved from a funding standpoint, which is a good thing. We still do get some money from grants. The employer members of Leapfrog actually do pay some small membership dues. And probably the largest portion of revenue actually comes from data sales. So the data we collect from hospitals about their quality and safety practices actually does get sold. The big, large national health plans in the United States, Cigna, Aetna, United Healthcare, all purchase this data set. They all find it to be an incredibly valuable data set. It's also sold to some third parties, entities like WebMD, if that's something you're familiar with. Castlight as well. I know there was a mention of that sometime here recently. So I really want to talk about two different public reporting initiatives that the Leapfrog Group is involved in. The first one is the Leapfrog Hospital Survey. This was an initiative that was launched in 2000. It's done annually, and it's actually a voluntary initiative. The second initiative is what we refer to as the Hospital Safety Score. This was launched in 2012. It is released 2 times per year, in the spring and the fall, and it's actually a non-voluntary effort. So the Leapfrog Hospital Survey is an annual survey of hospital quality and safety practices, and as I mentioned on the last slide, it was started in 2000. It's a voluntary self-reported survey. So as I talked about, in Seattle, it's Boeing who's sending letters to the Seattle area hospitals asking them to complete the survey. It's a voluntary survey, so some hospitals choose to fill out the survey, other hospitals choose not to. And it's a self-reported survey, so hospitals themselves are actually reporting on what they're doing in key quality and safety areas. The Leapfrog Group has actually, over the years, developed quite a robust quality assurance process to ensure that the data that hospitals reporting are as truthful and accurate as we can ascertain. We actually last year launched an initiative to actually have folks go on site to hospitals, to sit down with hospitals and review their answers and have hospitals provide documentation that supports their answers. One of the key tenets of Leapfrog from the very beginning was what we refer to as bricks and mortar reporting. In the United States, hospitals are often part of health systems. They may have multiple campuses of the same hospital. The early research showed that quality and safety actually can vary across campus. And when patients think of a hospital, they don't think about a health system. They think about a physical building at the corner of Main Street and the other street. And so we've very early on made it very clear that hospitals needed to report by brick and mortar facility or by individual campus. And that's really unique to Leapfrog in terms of public reporting in the United States. The reporting the federal government does is by Medicare provider number, which is a billing number, and often multiple hospitals will share that same billing number. So those data are actually aggregated together. The Leapfrog Hospital Survey actually has data that's available nowhere else. And where possible, we try to use endorsed and aligned measures. In this latest version of the Leapfrog Hospital Survey, we've had about 1,800 hospitals report to the survey. That's out of about 3,500 general acute care hospitals in the United States. So just to give you an idea of what we collect in the Leapfrog Hospital Survey, we've really categorized these into 5 domains of healthcare quality and safety. The first one we focus on is medication safety. We ask hospitals to report about their adoption of computerized prescriber order entry systems to order medications for their patients. These are systems that have decision support. So if a patient has an allergy to a medication, the prescriber, the physician, should receive an alert that if they're prescribing that medication for that patient, that that's actually not a good thing to do, and they may want to reconsider what they've done. We've also started to ask hospitals about their medication reconciliation practices and what they're doing to assure the quality of those to make sure that patients have the correct medication list. The second domain we focus on is inpatient care management. This includes areas such as the use of intensivists to staff the ICU. So intensivists are physicians who are trained in critical care medicine. And the literature is pretty clear that using intensivists to manage or co-manage patients in the ICU can reduce ICU mortality by up to 30%. Another example of inpatient care management is appropriate use of antibiotics. Nationally, we launched a big effort around antibiotic stewardship to make sure that we are being good stewards of antibiotics, not overusing them. And so we ask hospitals what they're doing in that area. The third area that we've actually put a big focus on in recent years is maternity care. So Leapfrog's purchaser members primarily employ a lot of individuals of a childbearing age. And so they're very interested in the quality of care in US hospitals for maternity care. We collect data on cesarean section rates, as well as elective deliveries before 39 completed weeks. Since its inception, Leapfrog has actually been focused on high-risk surgeries, so the literature was very clear that for certain high-risk surgeries, that the variation in mortality and complications between hospitals could be a 10-fold difference. There's a lot of literature that supports a volume-outcome relationship. So hospitals that do more of a procedure have better outcomes than hospitals that do fewer of them. The 2 surgeries that I would highlight here that have shown to have the greatest variation are esophageal resection for cancer patients and pancreatic resections for cancer patients. These are highly complex technical procedures, and you definitely want to go to a hospital that has a lot of experience with those. And the 5th area we focus on is hospital-acquired conditions. This includes areas such as healthcare-associated infections, so that's central line-associated bloodstream infections, catheter-associated urinary tract infections, MRSA, C. diff. We also collect data on pressure ulcers and falls. So as I mentioned early on, Leapfrog has had a strong commitment from its inception to transparency, and that the data we collect from hospitals about quality and safety is data that we would share with the public so that consumers and purchasers can use that to make good decisions. Just to illustrate how we report out the data, I've selected 3 hospitals in the New York area: Coney Island Hospital, Hackensack UMC Palisades, and Interfaith Medical Center. And just for purposes of an example, I chose the maternity care section. So we're measuring early elective deliveries before the 39th completed week, cesarean section rates, episiotomy rates, and adherence to best practices for maternity care process measures. And if the hospital does perform high-risk deliveries, we also have some measures around that as well. Leapfrog reports out its performance in a cell phone bar methodology. I believe this would be a universal concept, that 4 bars represents the best, 3 bars would be next, 2, and then 1 bar. And we've actually assigned some labels to those. So 4 bars we refer to as fully meeting the standard. So these are hospitals that have met the target of performance that we're looking to achieve. The next level down is substantial progress towards the standard. Then there's some progress towards the standard. And the 1 bar is willing to report. So we do want to give hospitals credit for willing to be transparent. As I mentioned earlier, hospitals are asked to report to the survey. It's a voluntary survey. If the hospitals choose not to respond to the survey, we reflect them as declined to respond. So Leapfrog is used really by both healthcare purchasers and hospitals. Purchasers use it as a source of public reporting that provides them with national comparisons. So a lot of the employers that I mentioned on my first slide are very large employers with employees in all 50 states. So to have a way of measuring quality and safety in a standard way across all of those localities is actually really important to them. The one statistic that I like to throw out is FedEx actually claims that they have an employee in every zip code in the United States. The zip code is what we use for the postal service. So they literally have someone living all over the United States. So for these large companies, having national standards of measuring quality and safety is important. A number of the purchasers have started pay-for-value programs or pay-for-performance programs, so these data get used in that way. Contract negotiations, so when the purchaser and the health plan sit down with the hospital to talk about next year's rates, they actually bring data about the quality and safety of the hospital. And that becomes part of the conversation in terms of setting rates. There are some purchasers that have used quality and safety data to actually design different benefit strategies. I'll give one example on a future slide that's really worked really well. And the final piece that I really think is incredibly important is we really want our purchasers to engage their employees. There seems to really, at least in the United States, a gap in knowledge that there is differences in quality and safety between hospitals, and that those differences can actually mean the difference between life and death for the patient. So we really want to make sure that our employers are educating their employees on the importance of quality and safety. For hospitals, they use the data to predict their payments around value and pay for performance. Allows them to nationally benchmark themselves against other hospitals. They use their data to help them identify areas of quality improvement. It serves as a gold standard for demonstrating transparency. And it actually helps form direct relationships between employer purchasers and the hospitals themselves. So as I mentioned on an earlier slide, we have been, for the last 2 years, collecting data on cesarean section rates in US hospitals. And this is the first time in the US that we actually are getting hospital-level data across the United States for cesarean section. And we're using a measure called an NTSV, which stands for a nulliparous woman with a term singleton baby in a vertex position. So these are first-time births, they're low risk. There are some contraindications for the measure, but these really should be a very infrequent occurrence. Based on a national panel that we gathered, the recommendation was that the rate should be at or below 23.9%. And in our first year reporting, we found that 60% of hospitals were above that rate of 23.9. And we actually see in an individual city that we see dramatic variation. So in an East Coast city, one hospital has a 10% C-section rate, another one has a 54% C-section rate. And that pattern continues through the Midwest of the US as well as the West Coast. Another area where I think we've really shown some progress is in early elective deliveries before the 39th week of gestation. So at least in the United States, we've often defined a pregnancy as term if it reaches the 37th completed week. And there was a growth in the number of babies that were being born between the 37th completed week and the 39th completed week. And those doing research in this found that a large number of those babies were actually winding up in the neonatal intensive care unit. They were having higher rates of respiratory problems, and that the outcomes for these babies were not as good. And so it became pretty clear, and as it turns out, those last 2 weeks are actually really important to the baby in terms of their brain development, in terms of their lung development. And so if there's no need to have them come out before the 39th completed week, waiting is better. So we were seeing an increase in the number of elective C-sections, inductions that were happening to have the baby come early. So when we first started collecting these data, the national rate was about 17%. So 17% of the babies born between the 37th and 39th weeks were being delivered electively. We now have about 1,300 hospitals that report on this measure, and we're down to a rate of about 2.8% nationally. And so this next slide actually sort of shows you the improvement in performance. So this is a measure where lower performance is better, where lower performance is desirable. So in 2010, we started with 17%, and we have worked our way down to 2.8%. We have set 5% as the national goal. And I think it's really just a great example of how transparency really has helped galvanize improvements in quality and safety. So I talked a little bit about this earlier, but I think it's important to repeat. So why do hospitals actually choose to report to the Leapfrog Hospital Survey? By participating in the survey, they can create a culture of transparency. They can benchmark their performance. It allows for public recognition. They can create a performance improvement plan, and they can demonstrate their commitment to transparency and quality and safety improvement. So as I mentioned earlier, one of our success stories has actually been the state of Maine. So the United States has 50 states. The one in the farthest northeast corner is one named Maine. It's beautiful. The Atlantic Ocean is along the east with many lighthouses. And the state of Maine actually buys healthcare benefits on behalf of their state employees. So these are people who work for the state, and their benefits are bought by the state for them. And what the state decided to do was that for hospitals that used high-performing hospitals, so hospitals that did well on the Leapfrog Quality and Safety Survey, their deductibles were waived if they went to that hospital. If they chose to go to a hospital that didn't do well on the Leapfrog Hospital Survey, they had to pay a $250 deductible. There were actually a number of employees who were pretty upset that they needed to pay a deductible and actually put pressure on the hospitals to start reporting to the survey. And at this point, we actually have 100% of hospitals in the state of Maine that report to the survey. We've seen excellent improvements in quality. And Leapfrog does put out an annual top hospital list, and 6 hospitals on the 2015 list were from the state of Maine. So the other initiative I want to talk briefly about is what we refer to as the Leapfrog Safety Score. So in 2011, Leapfrog's board of directors was getting frustrated that we had sort of plateaued in terms of the number of hospitals that were completing the survey, and they wanted information, a way to understand the quality and safety of hospitals across the country, even those that don't report to the Leapfrog Hospital Survey. And so that's where we came up with the idea of a hospital safety score. So this score is specifically focused on patient safety. And we see as patient safety a much more narrow construct than the broader construct of quality. Our expert panel helped us define safety as freedom from harm. So the measures we chose for this safety score hopefully reflect that construct of patients being saved from harm. And the goal was to report this out using a letter grade methodology. So in the United States education system, students are given a grade of A, B, C, D, or F. A is the best, F is the least best. And this has actually worked pretty well to really quickly communicate to someone the overall safety of a hospital. So the Leapfrog Hospital Safety Score is actually made up of 30 measures. We have 2 domains, a set of process and structural measures and a set of outcome measures. The process and structural measures include things like the use of computerized physician order entry systems, the use of intensivists to staff ICU, a series of safe practices endorsed by the National Quality Forum, as well as some of our patient experience domains around communication. For the outcome measures, these are a number of measures that include things like falls and trauma, hospital-acquired infections, as well as some patient safety indicators as well. So this grade is also publicly reported. We do give the letter grade, and we do give some additional detail as well about how each hospital does on each of these safety scores. The measures that are in italics, I'm not sure if that's easy to see or not, but when we create a hospital safety score for each hospital, we're using both data from the Leapfrog Hospital Survey, and then we're also using some data from the National Medicare database as well. So the measures that are in italics are actually the ones that we're taking from Hospital Compare, which is where Medicare does its public reporting of hospital performance. So we're actually blending data from those 2 data sources to get a more complete picture of safety of the hospital. So if one goes to hospitalsafetyscore.org, one can see the grades. You're able to search by zip code, you're able to search by city, and you can actually see how each of the hospitals do. So each letter represents actually a hospital. So the greens are the A's, the blues are the B's, and it doesn't look like in Connecticut there are any F's. So one of the areas I was asked to touch on today was the applicability of the Leapfrog model for emerging countries, and specifically perhaps opportunities to bring something like this to Brazil. In the United States, approximately 50% of our citizens get their health insurance privately through their employers. Brazil actually has the 2nd largest private health insurance population in the world, only after the United States. And the growth of the middle class here in Brazil offers, I think, an abundance of opportunity. The Leapfrog model really works best in a country where you have a significant private insurance market. And a key tenet, as I mentioned earlier, is that those that use and those that pay for the healthcare system have a right to know how it's operating. I think another key is what relationships do employers and purchasers have with hospitals? Do hospitals respect the purchaser voice enough to put forth the effort to voluntarily and transparently report their quality and safety data? And does the private health insurance market have enough of a share of patients, i.e., do they have enough leverage to make sure that leadership care about this audience? I would say in the absence of other data sources, a survey-like approach might be a good place to start. So coming to a close, I did want to share some of the successes we've had with this model in the United States and some of the lessons that I think we've learned along the way. Maybe if we could turn back the clock 15 to 20 years, what would we do differently? So one of the successes we've had, and I think Leapfrog has a lot to claim around this, is they've made transparency a norm of sharing quality and safety data. Leapfrog was probably 4 to 5 years ahead of the federal government in transparently reporting data. They've sent a clear signal to healthcare providers that purchasers care about the quality and safety, and they care a lot actually about quality and safety. These are their employees that you're harming. It's their family members. It's their retirees. Leapfrog's been a good partner with the federal government. We've worked very closely with Medicare on a number of initiatives, specifically in driving value-based purchasing efforts. And we've sent a clear signal that high-quality, safe care will be recognized. Now, what are some of the lessons learned? So if we could do this all over again, what would we do differently? So one of the things I think we learned early on is sometimes the largest employer in the market is actually the hospital itself. So for instance, in St. Louis, Missouri, there's, I think, 3 large hospital chains, and they're actually the largest employers in the city. So that's an example where we've had a little difficulty getting traction for those hospitals to report. We've also had some employee pushback on employer efforts to what I like to call steer or tier. So when I talk about employee benefit designs, one company in particular wanted to tier the hospitals based on how they did on the Leapfrog Hospital Survey. And the unions at that employer actually pushed back really hard and said, we don't want you, the employer, getting between us and our healthcare providers. So that was an example of where the employer thought it was trying to do the right thing for the employee, and the employee really didn't want their involvement. And on a broader scale nationally, I think some of the lessons learned is we launched these efforts without a clear vision of what we meant by quality and how we would exactly measure that. So any efforts you can do on the front end to really think about what is quality, how are you defining that, how will you measure that? We've had a significant lack of investment in measurement science. Most of the work we've done around performance measurement has come from the private sector. It hasn't come from funding from the government. And I would say the final piece that we have maybe learned is that patient experience is important, and we were a little late to recognize that. So in conclusion, just wanted to talk about some of our future activities. We've actually seen some good growth in our survey participation. We've had about a 50% growth in the last 4 years. We've gone from 1,200 reporting hospitals in 2012 to about 1,800 hospitals this year. We're constantly evaluating the types of information we collect through the survey. Areas that we'd like to include in the future include surgical overuse. So I talked earlier about the volume-outcome relationship, and that the literature is pretty clear that hospitals that do more of a procedure have better outcomes. But we need to counteract that with making sure that all those surgeries are appropriate. And we need to really engage patients in shared decision-making so that they understand what are their options besides surgery. We definitely want to include more measures around pediatric care. And we're very interested in the area of diagnostic error and accuracy. And an initiative that Leapfrog is hopefully launching in the next year is, as more surgeries are being moved to what we refer to as ambulatory surgical centers. These are surgery centers that are off-site from hospitals. We're very interested in understanding and measuring and reporting on the quality and safety of those. So with that, obrigado. Thank you.